Okay, another case. Next candidate.
Yes, sir.
Okay, how are you, my friend?
I'm good, sir.
Okay,
Request me, please.
I'll give you the control, but now this is a case of trauma fall from height.
Yes, sir. So I have been provided with the frontal radiograph of the chest where I'm seeing a displaced fracture involving the lateral end of the right clavicle. Otherwise, right acromioclavicular and right glenohumeral joint appears congruent. There is no
Good,
there is no pneumothorax or
good.
hemothorax. There is no obvious displaced rib fracture on the right side or on the left side also. Um,
So no rib fractures.
no, yes, sir. No obviously seen displaced rib fracture.
Okay, but as the patient fall from height and has right-sided chest pain.
Right side chest.
I'm helping. I'm helping. Okay.
Yes,
You see any irregularity here? I know it's subtle, but you see it here.
yes, sir. Yes, sir.
Okay.
Small.
And also some bone fragment here and some irregularity. So suspected rib fractures. It's okay. So
Yes,
yes, agree, my friend. It's a clavicle fracture, suspected rib fractures. But whenever you suspected rib fractures, okay, it's advisable to perform a CT scan. It's very important. No mediastinal widening here, يعني just subtle, maybe positional, and no pneumothorax, intact hemidiaphragm to rule out any diaphragmatic hernia. Okay, and of course, the patient is supine, multiple ECG lines or IC. I'll give you now this or this one. No, this one. Okay, candidate number 6. Yes, good.
yes, sir. So
Okay, you have the control.
I've been provided. Now I'm scrolling, sir. Unable to
Yes, yes.
scroll.
No. Just scroll. Okay, I don't know what's happening. Yes.
No, it's okay,
Good.
sir.
Yes.
So I have been provided a CT scan of the chest bone window. So here on the right side, we are seeing a displaced fracture of, I'd like to count the rib from cranial to caudal. And we are also
Okay,
seeing a lateral end of clavicle fracture.
good.
So from third, fourth,
Roughly speaking, because
yes,
we
yes.
have also,
Yes, at
yes,
multi levels, we are seeing from
good,
third to sixth, we are seeing a displaced fracture with associated hemothorax on the right side with
good,
underlying lung parenchymal collapse.
good.
Uh, there is ICD intercostal drain is seen with its tip.
Yes, likely in the pleural space. Okay.
Yes,
And
sir.
yeah,
Yes, sir.
yes, good.
Uh, yes, sir. It's going. So now bilateral pleural effusion, left side minimal effusion is there. I'd like to with multifocal parenchymal contusion. However, I would like to see a lung window also.
Okay. When you ask for lung window, I'll give you lung window. But take
Yes, sir.
care. Okay, you left the bone window.
Yes,
Okay,
sir.
obviously I
So,
missed something. Okay, no, continue.
uh, so here with endotracheal tube is seen
Good point. You
in
should start
situ.
with this endotracheal tracheal tube and nasogastric tube, okay, and any central venous line. Very good.
Yes, sir. So, going from cranial to caudal, I'm seeing multiple areas of parenchymal contusion, ICD, and I'll just go to the caudalmost portion of the scan to confirm the tip of the nasogastric. However, it
Good.
is
Apparently
uh,
in position. Okay, good.
yes, sir. So,
In
I
my
would like
routine
to see
practice also.
in my routine practice, I would like to see, since this is a case of a trauma, I would like to see a sagittal to look for a vertebral fractures.
Good,
Uh,
good point.
and I
And
will
also mediastinal window for what?
mediastinal window to look for
Any vascular injury.
mediastinal. Yes, sir.
Yes, any mediastinal hematoma, for example. Very good, my friend. Okay. Nothing in the vertebrae and nothing added in the mediastinal window. So, what is your opinion? Just a minute. Okay, I will close the other candidates. Okay,
So,
okay.
concluding this case, this is a case of trauma having a
Mm,
lateral clavicular fracture with displaced lateral clavicular fracture and
mm.
right-sided multi-level posterior ribs, posterolateral ribs involvement from third to sixth with
Very
associated
good.
hemothorax
Very
without
good.
any obvious pneumothorax sin. Th- I would like to alert the referee, urgently alert the referring patient about the finding, and would recommend
Mm.
further orthopedics referral urgent.
Good, good, good. Okay, my friend, you missed a major find here. What? Why? It's good you ignore now the clavicle, but there is a lateral rib fracture and displaced and some fusion. Very good. And it's multi-level. Okay, what else? In such a case, you should assess the posterior ribs.
Yes.
You assess the lateral. It's grossly evident. Okay, let's see the posterior ribs from up down. From even the first, okay. From the second rib, oh, I have a fracture. And the third, fracture. Fourth, fracture, fracture, fracture. You see multiple posterior rib fractures associated with, in the same ribs, multiple lateral rib fractures. Diagnosis will be
Please.
plate chest. Yes, it's an emergency. Unfortunately, it's missed on the first look. What happened later on? Oh, a flail segment is formed, and of course, some collapse of the lung. So take care, my friends. In case of chest trauma, I think everyone, even the patient relatives, will detect these fractures, but only you will correlate this one with this one. Multiple fractures in the same rib, at least two fracture, at least three or four successive ribs, it will form a flail segment, and this is called the flail chest. It's a surgical emergency. Of course, this need surgical fixation. A usual simple rib fracture doesn't need surgical fixation, but flail chest, surgical fixation, blatant screw. Okay, thank you, my friend. Thank you. Well done, يا boss. Of course, we should assess lines and the tubes, my friends. Okay, central venous line in position and endotracheal tube and the nasogastric tube. Don't forget any lines and the tubes, and also the intercostal chest tube, which is present in the lower part of the lung, likely within the pleural cavity. Okay, well done, my friend. But we didn't finalize the trauma. I think this case also a trauma, and we will add a new or another important point in this case. Who is the next candidate?
Do we have candidate three? Candidate three?
Yes, I'm here. Yeah, yes, I'm here.
Okay, okay.
Yes, sir.
Uh,
Good
okay.
afternoon, candidate 3 here.
Good afternoon, ya boss. How are you?
Yeah, I'm fine, sir. Thank you.
Okay.
Hope you are doing fine. Yeah.
Thank you. Alhamdulillah. Okay, my friend, a trauma, motor car accident. What do you see?
Okay. Provided with frontal chest radiograph in supine position for a patient who has who came from a motor accident trauma. I'm looking at the lungs in the bilateral apical region. I don't see I see the absence of vascular markings. I want to locate. I want to see for any visceral edge.
Good.
It's
So
not
you
window.
suspecting
Yeah.
what?
Yeah, suspecting bilateral apical pneumothorax. However, it appears to be small size.
Mm,
I am not able to see the visceral edge clearly to make it
so
confirmatory
not
in such
definitive.
situation.
Good.
So
So
not
not definitive.
definitive.
Good.
In such situation, lateral shoot through lateral decubitus may help in the diagnosis. Okay. Apart from that, bilateral lung parenchyma shows slight haziness. The film itself appears slightly underexposed and maybe positional due to supine. I am looking lung volumes also reduced, but that also may be positional. In the view, I also see that the mediastinum, in coming to mediastinum, I see the abnormal widening of the left side of the,
Excellent. Now
left,
I will
left
stop
of the,
you.
yes.
I'll stop you
Mm,
because this is important point. You
mm,
described some negatives, okay? Some points you
yes.
are not sure, and
Mm,
now you are sure
mm,
of this. The
yes.
order of
Mm,
findings.
mm,
This is important, my friends.
mm,
You may face some
mm,
examiners, very hard examiners. Don't
mm,
say negatives. Okay. By the
mm,
way, if the examiner talk to you by this way,
mm,
you have to
mm,
remain calm. Please,
mm,
you
mm,
have to
mm,
remain calm. Not all examiners are kind. And
yes.
unfortunately, I have many friends
Mm,
fail in the
mm,
exam because they
mm,
lost their
mm,
nerve. When the
mm,
examiner talked to
mm,
them, like this,
mm,
especially
mm,
female friends, they couldn't
mm,
continue the exam in a proper way, and they lost
mm, mm,
the
mm,
exam. So please, you
mm,
have
mm,
to remain
mm,
calm.
mm,
Start with the positive
mm.
findings first.
Okay.
Yes, we
Okay.
have here
Yes.
mediastinal
Yeah.
widening and some
Yes,
opacity.
I
Okay,
can see, there is an abnormal vessel widening in the upper part, and also I can see that it is obscuring the descending aortic outline, which is not,
good,
which is obscured by this one. In the case of trauma, it is suspicious for any mediastinal injury with hematoma, mediastinal hematoma formation. So
good,
I would like to, I am concerned about any aortic injury or
good.
aortic syndromes in this case. However, the left-sided, the classic apical pleural cap, I'm not seeing on the left side. Also, in the CP angles, I'm seeing that no
Good.
CP angles appear clear, so there is absence of pleural vision on, especially on left side.
Good.
Some haziness is noted in the left mid zone, which could be due to which could be due to contusion of lung,
Yes, yes,
or due
this
to
one.
some, or due to collected blood. I mean, percolated blood
Yes,
along the
maybe
bronchi.
pulmonary contusion. So we are suspecting mediastinal
Yeah.
hematoma, some
Yeah.
pulmonary
So
contusion,
for
no rib
I now
fractures,
to
and
no bony injury. I don't seeing the sternum and the vertebrae also to for any bony injury.
good,
But I don't see any abnormal bone injury in the sternum or
good.
vertebrae. No rib fractures. So this
And the
needs an
intact
urgent
hemidiaphragm.
finding. Yes.
Why I mentioned the
Yeah,
intact
because of
hemidiaphragm?
because of trauma to rupture, diaphragmatic
Good,
rupture is a serious
good,
complication in case of motor vessel high speed trauma. Yeah.
good,
So I will want to inform this finding urgently to referring physician, arrange for an urgent CT, CT autogram or CT contrast test for
good,
this case.
good, good.
And yeah.
Okay,
Okay.
I'll give you this
Mm,
case. Can you ask for
mm.
control?
Yes, sir. I have requested.
Okay,
Okay. Mm. Yes. So,
just one click,
uh,
then you can scroll.
yeah. Uh, scrolling.
Yes,
Yeah, it's coming. Thank you. So I'm scrolling through this the CT scan axial section contrast image of the chest. Just I will take a moment to scroll through the finding,
good.
and then I will go to the last cut. And now coming back, I'm scrolling back again. So here I notice there is in the left lung. Oh, there is in the left lung there is some filling defect in the vessels are noted. There is some filling defect. And these are some filling defect I am seeing in the vessels on the left side veins. I think here. This one thing. Apart from that,
Okay,
there is this heterogeneous opacification in the left lung, which I will see in the lung window, which represents the lung contusion, as we saw in X-ray. Now looking at the aorta, sorry, jumping. So sorry for the.
No
I'm
problem.
trying to choose the outline of aorta from the root itself. Yeah, aortic origin is unremarkable. Aortic root and
Good.
origin is unremarkable. Yeah,
Good.
there is. I'm also looking. There is no the discharge of aorta and descending aorta. There is no aneurysmal. I mean, it's ulcer formation or a hematoma or any sort of aortic this one. So now I'm looking for, yeah, I could see a faint at this level, a faint, I can see a flap like
No,
thing.
no, no, no. It's just
That
artifact. Artifact. Okay.
that is
Okay.
artifact. Okay.
Good.
Yeah. So now I'm concerned about the other vessels. Even the hematomas can be formed by the SBC and rupture and other
Good.
things. I'm looking at the venous system. Yeah. So looking at the vein, SBC is intact. Looking at the brachiocephalic is intact. This area, some filling defect, I am not
No, no,
sure at
you
this
can
point.
ignore it. It's symmetrical
Ignore it.
bilateral.
Okay.
Look
Yeah, yeah,
bilateral.
yeah, yeah. Okay.
It's okay.
Okay. Yeah, yeah,
Okay.
yes.
Okay.
It's due to cuts. So now I'm looking for any other vascular injury. Uh,
Good. Good,
I
my friend. So, can
yeah,
you
yeah. This so the soft tissue. Yeah, I can see that the significant soft tissue area is noted anterior to the aorta, arch of
good.
aorta at this region, and the I mean retrosternal and left sided.
Yes,
So
because you detected
trachea.
mediastinal widening on the
Yeah, yeah,
radiograph, and I
yes.
need
So yeah,
explanation. Okay, good,
yeah.
good,
So there is a soft tissue of specification in this area. Also, I
good,
will look the tracheobronchial tree in the lung window for any rupture or
good,
pneumothorax formation,
good,
which is not, which I will check in the lung window, tracheobronchial tree and the branching.
good.
So I am not
So,
getting any extravasation. I am not getting any extravasation of contrast in these images.
good.
Yeah.
Excellent. No
So mm,
extravasation.
the
Very good,
obsession.
very good point.
So
Mm.
and no thoracic, no, it is not fatty density to for any thoracic duct rupture, which could be because of, yeah,
So,
no, it's not there.
it's okay. Can you, because of time, يعني, usually in the
Yes, yes.
examiner, want you to finish
Mhm.
everything within 5 minutes.
Yes.
Okay,
So I
so
will
give some
inform the
pertinent
finding.
negatives, some pertinent
Yeah,
negative, and
yeah.
finalize.
So yeah, so aorta appears unremarkable in outline. There is a collection. There is a hematoma in the thorax. Mediastinal hematoma is noted. Yeah, the obvious finding is mediastinal hematoma, focal in the upper mediastinum. That's and with lung contusions.
Oh,
That's it. I would like to see the lung window
good, good,
for the and the bone window for the detailed
good,
evaluation of the
good,
fractures in this case.
good, good. I'll take the control
Thank
back.
you, sir.
You did it
Sure.
well, my
Mm.
friend. By the way, يعني we have here's
Mm.
lung contusions.
Okay.
Okay,
Okay. Mhm.
and no fractures. You should
Mm.
also assess
Mm.
or ask for
Mm.
sagittal
Mm.
for the dorsal
Yeah,
yes,
spine for
vertebra.
the spine. Mm.
Very good. Very good.
Okay.
You
Thank.
need some points, my friends. Just I want to
Yes, sure, sir. Yeah,
tell
yes,
you.
sure, sir.
Okay, okay. This is a trauma case. Go step
Mm.
by step. You
Okay.
mention the study. Yes, it's contrast
Mm.
enhanced. And which window is
Mm.
this? And start to if you see
Uh, uh,
the
mm.
cortex and the medulla, most
Mm.
likely it's bone
Mm.
rather than
Mm.
it's soft tissue. Good. But you
Okay.
detected
Okay.
something in the radiograph. Try to
Mm.
explain it.
Mm.
You mentioned the
First, yeah.
mediastinal hematoma later.
Mhm.
Later.
Mm. Mm.
Okay.
Yes.
No,
Mm.
it should be earlier. And again, if any mediastinal
Yeah.
hematoma, don't forget IVC
Mm.
and. Okay. And
Yes.
of course,
Yes.
in my routine practice, lung and
Mm.
soft tissue window.
Mm.
Okay, well done.
Mm.
What are the major
Mm.
what are the major sources of this hematoma? Either arterial
Um,
or venous.
or winners. Yeah.
Very good. You said
Mm.
normal aortic contour and no extravasation. But what is
Mm.
the source? Most likely venous. If not aorta, most likely
Yes.
venous. Try to trace the
Winners.
vein. What is this? Superior vena cava. What
This
is
is
this?
this. Yeah. Yeah.
Left
Brachiocephalic. Left.
brachiocephalic.
Sure. Yeah.
Why the left brachiocephalic is narrowed in this? What is this? What is this structure?
Mm. That bone is coming. Yeah. That.
Yes, the clavicle.
Cl
Why is the
clavicle,
clavicle
clavicle,
present here and
yeah, yeah. clavically impinging. Both are asymmetric. It's yeah, exactly. So it's a sternoclavicular dislocation and impinging. The
Yes,
clavicle is
very
impinging
good.
on the, yeah, in
Yes,
the
very good.
left
Very good.
midsection.
So this is a hidden case and commonly, unfortunately, commonly missed, my friends, and it's one of the dangerous signs here. Posterior
Yes.
dislocation of
Mhm.
sternoclavicular joint.
Mhm.
Usually missed because we don't assess this one routinely. No, it's one of
Yes.
the major findings. The first two rib fractures and the posterior dislocation of sternoclavicular, it can impede, it can cause injury to the thoracic outlet vessels. It can cause a mediastinal
Yes.
hematoma. The first two rib fractures, very dangerous, and the posterior dislocation of sternoclavicular joint. Okay, as in this case. Unfortunately, commonly missed, as you missed it, my friend. Okay,
Yes,
but
yes,
inshallah,
sir.
you will never miss it again. Okay.
In X-ray, I told, sir. Actually, by me, in X-ray, I told that I will see the sternum and this one. But coming here, I
And
forgot. Yeah.
it's definitely missed here.
Yeah,
Okay,
yeah.
because at the same level. يعني don't rely
Yes.
on plain radiograph.
Mm-hmm.
But CT,
Yes.
CT is يعني more perfect here. So whenever the examiner giving
Mm-hmm.
you bone window, please
Mm-hmm.
assess the bones. This is
See
very
the
important,
bones.
my friend. Okay.
Okay.
So mediastinal
Mm-hmm.
hematoma here, likely of venous origin, secondary to
Mm-hmm.
posterior dislocation of
Mm-hmm.
sternoclavicular joint. Again, it's vascular and orthopedic surgery as well for correction. So let's revise the major findings in case of chest trauma. In a bony fractures, first two ribs, posterior dislocation of the acromioclavicular joint. Again, the lower ribs. Why the lower ribs? Injury of a solid organs. Flail chest, and in my routine practice, I will check the sagittal for the dorsal vertebrae as well. Coronal is needed for diaphragmatic integrity because it may cause a compression upon the heart. Soft tissue window is needed for a mediastinal hematoma, especially aortic, plus or minus, or alternatively. Yes. Okay, I will the venous. I'll show you the case here. Follow this clavicle, my friend. This is a normal clavicle. Okay, دكتورة. Normal clavicle, and this is the sternum. So this is the normal sternoclavicular joint. What about the other clavicle? This is the other clavicle. Other clavicle. It's directed posteriorly. It's pointed posteriorly, and this is the sternum. So it missed its location here and displaced or dislocated posteriorly. In a posterior dislocation, it will compress the vessels directly, and the veins are vulnerable to injury. So this vein usually have a minimal leakage, but I couldn't see. Okay, posterior dislocation of sternoclavicular joint. Thank you, my friends.
Yeah, yeah. Thank you so
Oh,
much, sir.
welcome, welcome. Okay, Dr. Ali, any remaining candidates, يا boss?
Do you have any cases?
Yes, I have. Okay. Okay. Any candidates remaining?
There is one candidate left. If
Good. Good. Huh? Where?
candidate 7.
Yes, yes. Okay,
Hi,
دكتورة.
hi, Dr. Ismail. How are you?
الحمد
Ramadan
لله الحمد
Kareem.
لله الله أكرم. Thank you يا boss. رمضان كريم for all of you. Okay, I'll give you this case يا boss. Trauma, and we have an abnormality in the chest radiograph. Ask for control. Where?
Yep.
Candidate 7?
Yeah.
Okay, I give you the control. You can scroll.
Do I have to have a mouse over the edge to move the screen?
Yes, yes, you are doing good.
Okay, so I'm presented with a CT scan, axial slices through the chest in arterial phase. I just went through the scan quickly. I'm just going to have one more scroll so I convey my findings. Okay. So there is an entire tube placed in
Excellent.
the,
Good start.
thank you, in the esophagus, and the tip seems to be ending in the stomach, the distal stomach actually, in the appropriate place. There is also an ETT tube in situ, in the tracheal tube,
Good.
and the tip is well above the carina and the bifurcation of the bronchi. There are several abnormalities bilaterally. I can see that there is collapsed segments of lungs, but I would like to examine this further on a lung window.
Good.
On the soft tissue window, I can't see any pneumomediastinum or pneumopericardium or hemipericardium. There is some surgical emphysema on the anterior chest wall on
Good.
the right side, and therefore I'm suspecting there is rib fractures, and I think there is rib fracture that I can
Good.
see here.
Good.
Now I would like to examine this further on a bone window.
Good.
There is also several rib fractures on the left side that I can appreciate as well as I'm scrolling.
Good. Good. And surgical
Um,
emphysema on the left side as well. So have bilateral rib fractures, bilateral
And-
basal lung consolidation. Okay.
Yes.
No definite pneumothorax or pneumodiastinum in this window.
Yes.
You mentioned no pneumothorax and pneumodiastinum in this window. Are you sure?
No, I actually have to examine it on the chest window because
Okay.
I'm not sure
Lung
about
window.
these.
Okay.
Sorry,
Okay.
yeah, lung window.
Okay.
Thank you.
So very good, my friend. And pertinent negative pneumodiastinal hematoma. Okay.
Yes.
In this
Okay.
window. Good. What do you see here?
Oh, so yeah, I think it wasn't wise to comment on
Yes,
the
great
soft
lesson.
tissue.
Here, great lesson. Comment
Yes.
on every finding on its specific window. Okay.
Yep. Yep. So I retract that statement,
No
and I think
problem.
there's a
You
huge
can
left.
scroll huh,
Yes,
from
a
the
huge
start.
left. Yep. So sorry, I will get a proper mouse for next
No
session.
problem.
I'll
No
just
problem. It's okay. It's okay. And yeah.
uh,
Okay. You are doing well. You
thank
are
you very
doing well.
much.
Okay.
So there is a large pneumomediastinum on the left
I'm
that I
sorry.
can see.
Pneumothorax. Pneumothorax.
Pneumothorax, sorry.
Okay.
I'm so
Okay.
sorry.
No problem. No problem.
So there's a large pneumothorax on the left with partial collapse of the left upper lobe, and there is also collapse consolidation of the left lower lobe. There is also collapse consolidation of the right lower lobe, and there is no right pneumothorax that I can see.
Good. Good. We have here, you detected most of the findings, but we
Yep.
have a new finding here. Can you comment on the left lower lobe?
On the left lower lobe, yeah.
Yes.
So on the left lower lobe that is collapsed.
It's collapsed. Good.
Oh, yeah.
But
Yeah.
it's a dependent position and surrounded by pneumothorax.
Yes. So is this the fallen lung sign?
Excellent. Excellent. Great, yeah,
Um,
boss. Yes, yes. This is called fallen lung sign. Okay. When you
Yep.
see the collapsed loop in a dependent position, okay, it's
Mhm.
called fallen lung. Excellent. For this point, I'll give you another case, yeah, boss. Okay.
Thank
Good,
you.
good, good. I'll give you another case. You see here, my friends, it's dependent, like fallen fragment sign in fractured. Fallen fragment sign seen with which
Simple
fracture?
bone cysts.
Yes, simple bone cyst fracture, unicameral bone cyst. Yes, you see here, my friends, fallen lung sign. Very good.
Mhm.
Fallen lung can be seen with a lobe or the whole lung. This one
Yep.
or this one. Okay. Yes.
Mhm.
Very good, my friends. I'll give you now one last case. I don't remember this one, but it's okay. Sudden chest pain. What do you see?
Okay, so this is a frontal chest radiograph in a supine position. The pertinent abnormality is the veil-like opacity on the left hemithorax, which indicates left upper lobe collapse. There is, I can appreciate the left heart border as well
I'll
as
stop
the
you. I'll
diaphragm.
stop you. I'll stop you.
Yes.
Okay. You
Mhm.
mentioned veiling of the left lung field. due to left lower lobe collapse. You give me a diagnosis direct.
No, I actually retract that. Sorry.
Okay. Why? Lower,
Because I
before
think
volume loss. Before you give the diagnosis of a lower collapse, mention the signs of volume loss. Okay,
yes.
prepare me to yes, I'm hearing multiple signs of volume loss, so most likely will be collapse. But here the mediastinum actually is shifted to the maybe normal or even to the left side.
Shifted to the
Okay,
left side,
so,
yes.
yes, so the
Yeah.
opposite of a collapse. Good,
Yes.
good.
So there is no volume loss. I can also appreciate the left hemidiaphragm borders. And I think because this radiograph is supine, I am now suspecting that this could be a pleural effusion that is
Excellent.
causing this veiling.
Good.
Looking at the right hemithorax, I think there is a bit of upper lobe venous diversion, mild. I don't think there is any consolidation, and there is no
Good,
obvious
good.
pleural effusion.
So in the acute setting, till now, the patient has some pain, cough, vomiting. Let's say I'll give you an easy suggestion. Assuming the patient has, for example, hemoptysis, what
Yeah.
you will suggest?
If it is hemoptysis, I would be concerned that so hemoptysis with pleural effusion. I would be concerned that this patient is
I'm sorry,
congested.
hematemesis,
Oh, all
not
right.
hemoptysis.
Okay.
Okay,
All right. If there is hematemesis, then I would be concerned about a few points. First, is this pleural effusion coming from an esophageal
good,
bleeding varices?
good,
Also, I would scrutinize the mediastinum to see if there is any pneumomediastinum. And
good. Okay, now back
yeah,
to the history. Okay, sudden chest pain after episode of cough and vomiting. Which
okay.
diagnosis comes to your mind when you see this classic history?
Boerhaave syndrome.
Excellent, excellent. Yes, this is the way. Think of the يعني regarding the history, think of the history, then assess the case. Okay, you detected just effusion in the radiograph. Now you can scroll.
Okay. Okay, it is working. So I'm presented with an axial CT with contrast in the portal venous phase of the chest of the same patient that I've seen the chest X-ray of. So after going through the slices, I think I can now appreciate that there is a pneumomediastinum,
Good,
as there is gas within the mediastinum,
good,
and there is bilateral pleural effusions more on the left side,
good,
with an associated segmental atelectasis or passive atelectasis of
good.
both lung bases. I can't definitely appreciate a point in the esophagus that is perforated, but then I am now suspecting that this is esophageal perforation.
Yes, and even from the start, my friend, okay,
Yeah.
esophageal dilatation is noted.
Yes,
It's
esophageal
uncommon to
dilatation.
see the gas-filled esophagus like this, okay?
Yeah.
And followed by some fluid within the esophagus, then
Yes.
indistinct.
Yeah.
So you are suspecting Boerhaave syndrome. In my routine practice, I will check other windows and even
Yes.
we may give even oral contrast, okay?
Yes. Yeah.
They give oral contrast
Okay.
and
Okay. Is this the
scroll.
oral contrast?
Yes,
So I'm now examining the oral contrast phase of the same patient's CT. I'm just going to go through the slices in the slowest way possible to check for any extravasation of the contrast into the
good.
mediastinum.
Do you see any extravasation?
Yes, I do actually. There is an extravasation of the contrast into the mediastinum, and that's indicative of contamination. I think I would urgently contact the referring clinicians and inform them
Good.
that this patient would need urgent attention of upper GI surgeons and
Good.
likely surgical intervention. Yeah.
Good, my friend. Good, my friend. We have here, okay, give me the mouse, give me the control. Yes, I will take it back. Thank you. It's a clear case. You see here, choral contrast is noticed, then extravasation. It's Boerhaave syndrome. It's a definite case. Some hiatus hernia also is present. Sometimes vomiting, sometimes hematemesis. It's urgent, but the main finding will be a pneumomediastinum. A pneumomediastinum together with effusion. Here it's not classic, just effusion. But if you hear this history from the examiner, chest pain or cough or dyspnea after episode of vomiting, look for any pneumodystina and mention. Even pertinent negative in the average, yes. Tell the examiner, I know what I'm looking for. Okay, no definite pneumomediastinum. However, this case needs a CT scan to look for 1 to 3. Okay, well done, يا boss. Well done, يا boss.
Thank you very
Uh,
much, doctor.
Thank you, thank you. Thank you, Dr. Ali, for helping me. Inshallah, tomorrow. Okay, close.